So today we're having a conversation with stroke survivors. My name is Kayla Anderson and I work at Tallahassee Memorial Hospital. I am a stroke navigator there. I've been there for about 10 years in neuro the whole time. And we're here today to have a conversation about stroke because stroke is an awareness month. Our goal is to educate everybody on the signs, the symptoms, the risk factors that you could experience to prevent. Our hopes is to just prevent this medical emergency from happening in our community with you guys, with your families. We're joined by an incredible panel. Dr. Oliver, an endovascular neurosurgeon with Tallahassee Neurological Clinic and TMH, and Dr. Amy Neal. This is a primary care physician with Capital Health Plan. We're also honored to have with us today 2 stroke survivors and TMH patients, Katherine Balog and Gary Hansen, who both received treatment for their strokes from Dr. Oliver at TMH. Thank you for being here today. For those of us joining us virtually, if you have questions, please submit them using the Q&A feature on Zoom, and we'll be monitoring as they come through and answering in real time. So let's get started. Dr. Oliver, I'm going to start with some of the basics. What exactly is happening when a person is having a stroke?
The question was, what is happening when someone's having a stroke? And the answer is oxygen is not being supplied to the brain properly, whether that's from a hemorrhage or that's from a blockage of blood vessels that's preventing that blood from getting to the part of the brain. There is a potential in some folks for reversing some of these effects. And in a lot of people, there's not. If we wait too long, the potentially reversible portions are not reversible anymore. And this is where the phrase time is brain comes in. The longer we sit on that stroke, the less likely we are to be able to potentially reverse those symptoms.
Are there different kinds of strokes?
Right, so the 2 biggest categories for strokes are either hemorrhagic strokes, and that can be sometimes from an aneurysm, but more often than not from an aneurysm, and it's from a smaller blood vessel bursting, usually due to high blood pressure. And then ischemic strokes, where there's not a hemorrhage, but blood flow has stopped into an area of the brain because a clot has broken off, either from the neck or from the heart, and prevented flow from going into that part of the brain.
How would you say that someone could recognize that they're having a stroke?
The acronym that we've tried to reinforce to everybody is Be Fast. The acronym focuses on 6 different symptoms to look for, but the things we want to remember is that stroke is usually happening in one part of the brain. So we're looking for something to be lateralized. The left side's not moving, the right side's not moving. We can't talk, okay? So we're looking at the face, we're looking at the arms, we're looking at their speech. These are the big areas to think about. Yes, sir.
Is it always the left arm?
No, it can be a problem. No, it can be the right side as well. Okay. So there are people who have strokes that affect the brain stem, and this person may in fact just be unconscious. Usually, even in that setting, we still have something like the left side is moving better than the right side. More often than not, though, when we see somebody who is simply altered, let's say the word, they're not talking right, they're making words, but they're not talking right, that's not necessarily even a stroke, but it is a symptom that's going to bring somebody into the hospital. But more often than not, it's going to affect one side or the other. It does not always have to be the left side, it can be the right side.
And how urgent is this?
It is always emergent. Please do not sit on that.
Would you say that someone should drive you to the hospital or that you should call 911?
I would say that you should call 911, and the reason why is because it's going to happen faster and safer to have EMS do it. If you are out in the woods and unable to have EMS come to you, then you should probably get a ride. But that's not the case most of the time. Most of the time, we are able to get EMS to us rather quick.
Gary, I have some questions for you. Can you share your personal experience with us and how did you know that you were having a stroke?
I'm sorry, I can't hear you when you ask the question.
Sorry about that. How did you know you were having a stroke, Gary? And what did you do next?
Okay. So I had been watching a basketball game at home. I kissed my wife goodnight at halftime. It was my alma mater playing, so I wanted to watch the rest of the game kind of thing. My team won. I wasn't jumping off the walls. I was happy, you know, but I used the bathroom. I grabbed a cup of water. I walked into the bedroom, set it down on the nightstand. And when I sat down in the bed, it was just like snapping your fingers. I just had like this instant worst headache of my life. Well, I didn't know what to do with that. It's like, man, I'm not prone to headaches. So I thought I'll just lay down in the bed like I intended in the first place and hopefully it'll go away. So I looked at the clock. It was 11 p.m. Laid my head back. I'm laying there thinking, okay, what do I need to do? Just relax, rub my temples a little bit. A few minutes went by, nothing changed. So I looked at the clock again. It was 11:18. I thought, well, maybe if I sit up, just change my position, maybe that would help. Well, when I sat up, I got nauseated. I thought, uh-oh. So I made my way to the porcelain altar, knelt there, lifted the lid, and I proceeded to have dry heaves, just to be candid about it. That woke up my wife from a sound sleep. She came in and said, what's going on with you? I said, I just got the worst headache of my life. She said, do I call the doctor or the ambulance? And this is just what I said. I said, I think I'm going to just try and sleep it off. Well, fortunately, my wife had better sense than I did, and she went in and she Googled worst headache of my life was vomiting. The answer came back, get him to the hospital. And then the phone rang, and it was a doctor's nurse calling her back. And she could hear me in the background, said, he needs to go to the hospital. Don't try and take him yourself. Call the ambulance. So the ambulance brought me in, and I remember coming out of the ambulance on the gurney, and I saw it start to turn to the left, but I never saw the emergency sign. The next thing I knew, this is about midnight, I opened my eyes and there was a clock just like that one on the wall that said 5:30. And in my mind, I'm thinking it's 5:30 a.m. And there was nobody in the room, there was no sound, and I looked down at myself and I saw that I was in a hospital gown, looked like a hospital bed, and I said to myself, well, this isn't heaven. So I guess I survived a headache. And my second thought is I need to call DVPR, that's my state job, and I'm at the customer service window and they open at 8 o'clock and you better be there. So I said, I better call DVPR, but it's 5:30 in the morning, so nobody's gonna be there to answer the phone. So I fell back asleep. And the next time I woke up, the clock said 8 o'clock, which is, hey, that's go time. That's time to make the call. So I called and I didn't know anybody else's number. So I called my own because knowing somebody's going to be in my chair. And it turned out this friend of mine was there. We had a little mini hallelujah meeting, you might say, you know. And then my supervisor got on the phone and she said, well, dude, it's good to hear from you. She said, I told her I knew that the customer service window had to be open on Thursday, January 12th at 8 a.m. sharp, but I said I had a headache real bad last night. Looks like I'm in the hospital. I don't really know what's going on. And she said, well, it's good to hear from you, dude. She said, but you do know it's Friday, right? I said, no. She said, yeah, it's Friday. Well, you have to know this friend of mine, Christy. She's the kind of person that would tow you out into deep water, release you, and see what happens. That's just, you know, that's just her sense of humor, you know. So I thought she's giving me the hook, you know, kind of deal. I said, no, it's really Thursday, right? She said, no, it's really Friday. But it's good to talk to you, you know. And we'll talk to you later. And so she hung up the phone. And the next thing was Dr. Gray coming in to identify himself. And things went from there. But I have that 30 hours, as it turned out, I have no recollection. There's nothing, even when somebody tells me this is what you said, or this is who came to see you, or anything like that, it doesn't go like, oh yeah, now I remember. It's just, it's blank. And I asked Dr. Oliver about why that was, and his answer was, we have some very good drugs.
Thank you so much.
You're welcome.
Catherine, what about you? What were your signs and symptoms, and when did you realize it was time to go to the hospital?
So mine was a little bit different than Gary's. I remember everything, which is kind of a miracle, I think, occurs because I remember everything. It was 5 years ago, actually, this month. And my daughter had just been recovering from the flu. My husband was traveling, and I woke up that day not feeling great, and I said, oh no, I'm getting the flu. And I actually took a Tamiflu, but I felt something was off. And so I told my daughter, let me get ready. She needed to go to an activity, and went to take a shower. And when I blew my nose, I had that thunderclap headache, and I completely bent over, but came back. So my first thought was like, maybe this is an aneurysm, but I'm alive, so it can't be an aneurysm, because you always say, think that an aneurysm kills you. But then I knew something was not right, because then I started having nausea and throwing up, but I was not sick. So I decided to drive to my parents with my daughter, just to see what I needed to do. And when I got there, the throwing up kept happening. And I told my mom, something is wrong, because I'm not sick, but she's, a great Puerto Rican mom gave me every single tea, like ginger tea and all kinds of tea. And still the headache was not gone. It was not as bad, but it was just throbbing. And that happened on a Saturday. And same thing, you think that you don't want to be, just not reality. I pushed all the way through Wednesday. So Sunday, I kept doing things, not feeling great, and thinking that it was the flu, maybe getting better. Monday, I tried to sleep it off and called the school and said I can't volunteer, but I think I'm feeling a little bit better. Tuesday, and then Wednesday, went to the office, and by God's grace, my coworkers were there. I'm typically the one person in the office, and by myself, but at that point, my boss was there, my coworker. And I remember drinking this tea that one of my friends gave me from England. And when I drank it, that's when I think my aneurysm ruptured, and it was another horrible headache. And I completely got bent over. And then I was thinking, wow, this is a very powerful tea. But the most fascinating thing is that I remember having like not an out of body experience, but I remember seeing my coworkers and I was trying to speak, but I knew they were not understanding me. So they kept like looking at me and moving their heads. And then I just kind of made myself come out of it. And then my boss said, we need to take you to the hospital because I knew you had a horrible headache a few days ago. Mind you, my office was 2 minutes from TMH. So that's the reason why he didn't call the ambulance. At that point, he had a new car and he thought that he could really speed up all the way because he did. And when I got to the hospital, the most interesting thing is that I didn't have any stroke symptoms. I'm speaking, I regained all of my functions. My memory was intact. And then when they did the assessment, I said, I think I may need a CAT scan. They took me to a CAT scan. And that's when they asked me, have you fallen? And I said, no. And I had a bleed. They called neurosurgery, and Dr. Oliver showed up and he took over and saved my life. But I remember I remember everything going into the OR, every single person that was there. I remember the clock, there's a clock, and it was around 4:30, and I remember praying. And then when I woke up, it was around 8, I think. And all the nurses were around, but I came back speaking. And one of the nurses was impressed because when I asked what happened, and they said you had an aneurysm rupture in your MCA, the middle cerebral artery, but you're speaking, and I haven't shut up since then. And one of my friends, he was one of the ER doctors, said, you're one cool lady because you have coils in your brain. And then they explained I was in ICU for about 2 weeks and then had some anxiety, had to come back. But by God's grace, I had all of my, senses intact, all of my memory. I remember every single thing in ICU. I was I think at that point, the only patient that was speaking a lot. Yeah, and but it was a learning experience, just being an humbling experience, being there, and how the treatment, when they explained what happened, it was like coiling. They went through my groin, and then I have coils in my hand.
Thank you both for sharing that. What a lot of people don't realize is that strokes can be prevented. And so we'd like to move on and talk about how we can prevent a stroke from happening. Dr. Neal, what puts a person at risk for having a stroke?
Sure. So there are some things that put people at risk for stroke that you have control over, and some things you don't really have control over, like your age, your sex, ethnicity. These are things that we can't do much about, but it does help to be aware of them. In general, risk goes up as we get older. In young patients, there's an equal predisposition for strokes. And then as we get above about age 60, I want to say, the risk of stroke is higher in men than in women. And then women tend to do better when they do have stroke. We're not sure exactly why that is, but then the factors that we can control, probably the main thing is blood pressure. If I had a graph here, it would be blood pressure is sort of the main thing. They call it a silent killer for a reason. You feel fine and your blood pressure is higher than it should be. And as time goes on, that causes wear and tear on your arteries. And it is a factor that leads to the buildup of plaque in the carotid arteries and other places that can then go on to cause a stroke. It also is a big risk factor for not the clot kind of stroke or the ischemic strokes, but also for hemorrhagic strokes. Because if you think about what happened with you, the aneurysms that happen, they're like a blowout in your tire from too high of pressure is one thought there. Smoking, alcohol also play a big role. If you are a smoker, I think everybody is aware that it has other risks, but it's a good idea to consider quitting. The certain drugs also play a big role. Diet, a diet that's high in processed food, salt, can definitely increase your risk. Not getting regular exercise, or physical inactivity. We all hear sitting is the new smoking, and I think that is true. So the more activity you're getting, the less likely you're going to be to have a stroke. Being overweight also plays a big role. For every 1 unit increase in BMI, the risk of ischemic stroke increases by 5%. There is a somewhat protective factor. People who do have strokes with higher BMI, for various reasons, don't seem to have, they have a little better recovery rates, but it does increase the risk. So.
Thank you so much. What are the long-term consequences of a stroke?
We've just heard some really amazing stories from 2 people who don't have a lot of deficits after a stroke, but we did hear one, the amnesia or trouble with memory. Sometimes that whole phase, weeks, months, days, are a blur. And sometimes people say their mentation is just very foggy after that. Of course, we all know paralysis. It can be partial paralysis, or it can be a complete, like a flaccid paralysis that can happen. Speech problems, swallowing problems, trouble chewing, vision problems are one that people don't really think about too much, but sometimes people get to where they just can't see certain things. we have some ways of looking at what that might look like on images, but the vision can be a big problem. And then another thing that can happen to people is, went over swallowing. There was a big one that I wanted to go over that I'm forgetting now. I'll come back to it in a minute. Amnesia, right?
We'll get to it. I'm sure we'll hear it. What is recovery from a stroke like?
Recovery is marked by oftentimes a period of depression, frustration. Sometimes you have to simplify your life a lot, because you suddenly can't use your arm. You need a lot of help. You get to where you were going into work, you're doing all these things, answering phone calls, doing all this, and now, you have to take a month off and, learn how to write with your other hand all of a sudden. It's a period of rebuilding. It can be a period of, like I said, foggy memory, loss of independence is really very difficult. Loss of identity, because you thought you were, I thought I was a healthy person, and now you're kind of like, well, am I unhealthy because this happened? Your own personal identity can be affected, and loss of future plans. You thought you're going to retire, you're going to travel, you're going to do X, Y, Z, and all of a sudden you can't really do that anymore. You need to reassess and make other plans.
Can someone have a stroke and not know it?
Yes. Yes, absolutely. Stroke, we think of as being something that happens to the brain, either because of bleeding or because the area is not getting enough blood flow. And sometimes that area is so teeny tiny that you don't really notice it, or you thought you just had a headache, or you had a little headache, it was not a big deal to you, you were feeling kind of funny one evening, you were a little dizzy, and you just let it pass, and it was gone by the morning, and it seemed a lot better, and maybe you don't notice anything. But then when we do a scan a couple years later, we can see these teeny tiny areas where you have been having mini strokes or TIAs or what have you. But if they're showing permanent change, then I would call that a stroke. I would let Dr. Oliver also comment. And I do remember my other thing, it was dizziness. Vertigo is something we don't think of a lot with stroke, and vertigo is also very common, it's usually benign. But if you're also having trouble moving your extremities and coordinating things and falling over, that's something to pay real close attention to, even if you do have a history of some vertigo.
Thank you so much. Katherine, have you had any long-term effects from your stroke, and how has your life changed after the stroke?
I have not. I did deal with anxiety just because I'm a very controlling person and I couldn't control this. But other than that, light sensitivity sometimes, nothing major. I regained everything right away, or didn't lose anything. But in terms of living my life, just gratefulness, seizing the day, making sure that after learning a lot about strokes and the possible outcomes, that mine was a miracle and somewhat of an anomaly. I don't take it for granted, but trying to, at the same time, helping TMH as much as possible because of the care that they provided me. So we've done a fund through the foundation, a lot of people don't know about stroke, so creating something that can provide education for patients really behind the scenes. So we've taken it more from that gratefulness to do something bigger, and my anxiety is much better. At one time, my husband kept driving me when I would go to the appointments with Dr. Oliver, and one time I came by myself and he said, "You did it." "You drove by yourself." And I said, "Yeah, I'm a big girl again." Because you get scared that it was such a sudden event, So what if it happens now? What if it happens when I'm driving my daughter? So then I became pretty grounded with my faith as well, praying a lot. And yeah, and life is good.
What steps have you taken to try to prevent?
So
another
it was
one?
pretty healthy to begin with. I've kept the exercise, nutrition, more conscious about it, trying to balance stress quite a bit. So just keeping those things going.
Gary, what about you? Have you had any long-term effects and how has your life changed? And what steps have you taken to prevent a future stroke?
Okay. Well, I'm another happy story to tell in that regard. The night that they brought me in, or sometime in that first few hours, Dr. Oliver, after he had examined me and checked things out, told my wife that 20% of the people that had what I had didn't survive. And on average, about 60% were paralyzed or disabled for the rest of their days. Again, that experience what I had experienced. And then he said, for whatever reason, it seemed like about 20% get to walk away like nothing ever happened. And he said, I believe this gentleman, your husband, is going to be one of those 20%ers. And I tell people, indeed, by the grace of God, I'm here and everything works. And I was able to, well, after that 30 hours of no memory, kind of a thing, I was back to real time. I mean, I just thought it was Thursday, January 12th. And once I adjusted my calendar, I just, went on with life, you might say. But on that very first day, that Friday, they did an MRI just to make sure that there wasn't a tumor that was bleeding up into my brain, And then they asked me if I was ready to walk. Well, I had an IV and I had a gown. And so I said, yeah, I'm ready to walk. And so they gave me another gown to go on backwards, because nobody wants to see me walking away from them in that situation. And so I'm pushing my little IV cart, and the nurse is standing next to me, but not hanging on. And I just walked in a circle around the nurse's station, back in the old setup, the old unit. There were 10 beds, and they all were kind of like in a pie shape, in a circle, kind of a thing. And so the curtains are pulled open so the nurses can see the patients and everything. So I'm walking and I'm seeing all these people, and everybody there was bound up, bandaged up, propped up. Most of them had their eyes closed. Of course, I can't ask what happened to them or what's their prognosis, But as I saw the other 9 beds, I was just overwhelmed by the grace of God that I get to walk around and I know who I am, kind of a deal. And so I tell people, when the tears come, understand something. There's no pity party going on in this heart of mine. Those are tears of joy and gratitude, just like you mentioned. And so I tell people, I consider myself blessed beyond measure. And I thank God every day for the bonus miles. And so the one thing that's changed in my life, for sure, is that, again, by his grace and his strength, I like to come back to TMH for a cake every year. I wasn't bringing TMH a cake up to that point, but now I do. And if it says, TMH, thanks for saving my life, the most recent one 5 years ago, exclamation point, and then it says blessed beyond measure across the front. And I've told people, again, as he gives me grace and strength, I'll be back every year as long as I'm here on this earth, because I'm overwhelmed with gratitude and thankfulness and joy. So when the tears come, they're tears of joy and gratitude, not self-pity or woe is me or anything like that. It's always the positive.
Thank you, Gary. Oh, you can question it?
If I understand correctly, there's no test, MRI, CAT scan or whatever to show you had a TIA. My husband of 50 years, it's been almost a year now. He went numb on 3 places on one side. Didn't know the 4th place until a couple of days later. He didn't tell the doctor that either. Couldn't get him into a doctor, and so he says, oh, I'm just tired. 3 places like that to go numb. You know, so anyway, we go to the doctor, primary doctor the next day. There's nothing going to be showing what I understand. And then he tells me later there was a fourth place. I said, you didn't even tell me, or the doctor that. So I don't know. And again, you know, I thank God that, you know, it was a TIA because I think, oh, that's your warning or a big one, what I think anyway. I don't know if you can add any more to that.
Sure,
I'm happy to go.
well, I'll do a quick job at answering that. TIA, so, you know, there's strokes that leave a permanent mark on the brain and usually have some sort of deficit associated with them. And then there's TIAs, which I think of as kind of like a positive stress test, you know? Like something happened to you and that caused a little period where your part of your brain wasn't getting enough blood flow. It was enough to where it didn't damage it, but it was reduced and you were noticing something. There's other things that can cause numbness, you know, sometimes there's, you know, I've heard Guillain-Barré will sometimes be a little weird like that, or, you know, got into some sort of neurotoxin, you were handling some, you know, one of my patients had a cat flea thing that got on them and that caused it. Certain migraine symptoms can do this, but you know, it's something that, I mean, you're right to pay attention. You know, being like the strong silent type kills a lot of people.
That was actually part of our next question. So we learned earlier that Gary and Katherine both had hemorrhagic strokes, but Dr. Oliver, what about ischemic stroke and how do we treat it? And then what do we do at TMH as well for a TIA?
So I want to start by saying, this is a very close topic. I think everyone in this room could talk about a family member, themselves, or a friend who's had something that sounded like a stroke. And a stroke is a sudden and devastating event that occurs. The wrapping your head around what just happened to you is something that people struggle with for a long time. I have two very good patients and outcomes sitting up here in front of you to talk to you about this. And yet Gary's statistic is something that I still quote to people. 20% of people who have an aneurysm rupture are going to die before they make it to the hospital. 60% of them are going to look devastated. 20% are going to look good. And good does not mean they feel good, but they look good. They're talking, they're moving everything. They're going to walk out of the hospital whether or not they have a headache. That statistic does not always bear out for ischemic stroke. However, there are things that we can do to try and mitigate and or change our risk factors for them. The thing, your story, ma'am, is an excellent point. My husband had this thing occurring. It sounded like a stroke to me. I was concerned for him, and then he didn't say anything. And what's wrong with him? And that's a very common thing that I hear people say, right? Like, especially him, he won't go and deal with this. Because, not because men are stupid, just because they think, well, if it'll go away on its own. We tend to mitigate, we tend to blow things off. The bottom line is, what you did in bringing him in was the right thing to do. You want to have that checked out. Now, did it happen over a few days? Did you notice that he was having any motor deficits? No. So there are other things that can cause numbness in the arm. The first thing, as a neurosurgeon, the first thing I'm going to bring up is, well, is there something going on in his neck?
It wasn't just his arm, though, it was down one side.
Okay, so that would be something we would be
Places,
concerned
and then
about.
the next day, it's the fourth place, so four going all the way down.
So the most common things that we're going to try and mitigate are we being screened for atrial fibrillation? Are we treating atrial fibrillation? Do we have carotid disease? Are we looking for carotid disease? Are we getting an ultrasound on our neck? Those are all things that I would be saying, because there are a lot of strokes that we don't understand why they happen. We don't. But those are some big ones that we can go over. I would say the two biggest risk factors that are going to help us control the risk of stroke, but this does not cure it, nor does this completely mitigate the risk of stroke, are smoking and controlling our weight. Okay? Because the weight is going to contribute to trouble with breathing and sleep apnea. That's going to contribute to high blood pressure. That's going to contribute to a higher risk of stroke. If you have diabetes, you're not controlling your diabetes, that's going to contribute to stroke. The story here, I don't want this to be, I think that this should be something that we should come to this and say, I'm concerned about something, but I want y'all to walk away with some tools and advice on how do we move forward with concern, with trying to mitigate the risk of stroke. Your question, how do we watch it? How do we prevent it from happening? I would say that those are some of the biggest things that we can do. Okay, let's go ahead.
When you use the word overweight as being a risk factor, well, I've struggled with that, sir, for many decades now. So what is a good number? I mean, can I be 30 pounds overweight and it's not risk, and I'm not be threatened with a stroke, or can I be 40 pounds overweight?
Let's put it this way. First thing, I don't do preventative medicine. I'm gonna defer that to Dr. Neal. However, the way to think about it is not to say, okay, I weigh this much, therefore I'm not gonna have a stroke. That's wrong. You can be skinny and still have a stroke. But if you're not able to walk on one side of your body, the likelihood that you're gonna be able to rehab back is much better if you're not carrying as much weight, okay? Usually we're talking about morbid obesity as compared to I need to lose 15 pounds. All right. I don't think that there's a cutoff where we can say you're not going to have a stroke because you're skinny, or you're definitely going to have a stroke because you're this big. But I do think that by moderating and trying to decrease our weight, that we're going to be in a better position from a global health standpoint that's going to prevent us from having other health issues. I'll defer to Dr. Neal about specific numbers.
It's actually BMI of 20. Starts
BMI
out.
doesn't mean anything to me.
So you can probably talk to your doctor about it. I would have to know your height to give you an
I put
exact
one way about 180.
weight. You're 5'1".
Yeah.
So
I know I'm overweight.
don't have my chart in front of me, but so a BMI of 20, 5'1" is going to be about 120-ish. But so weight, you know, as it goes above a BMI of 20, so for every 1 point, and that's like your weight divided by your height or whatever, it's a ratio. For every 1 point that you're increasing your BMI, you're increasing your risk by 5%. But there is what we call the obesity paradox, where people who have a BMI that's higher, for whatever reason, seem to recover much better from strokes, which is a strange thing. We're not totally sure why that happens, but we do see more of them. And if you have an issue, you know, you're doing your best with your nutrition, your exercise, then the other things are make sure your blood pressure is okay, check on your cholesterol. If your doctor says you should be taking medicine for blood pressure, cholesterol, then, you know, make sure that you're coming up with a good plan that you're comfortable with. You know, I mean, you're the one who has to take these medicines. If you don't like them, let them know, but, you know, make sure that you're controlling the other things that you can control.
Are you wearing your CPAP mask?
Right.
Oh, yeah.
When you're wearing your CPAP mask, that is critical.
And if you know you have some issues, you know, some carotid artery issues, or you have super high cholesterol, you have a strong family history, maybe a baby aspirin or, you know, something along those lines can sometimes be worthwhile.
We're actually gonna have a Q&A at the end. We have a few things we want to get through, but we'll get to questions at the end in just a few minutes. Thank you. Okay, so I do have 2 questions for Dr. Oliver though. A, what is the treatment for an aneurysm and subarachnoid hemorrhage? And then B, what would be our treatment that we offer at TMH for ischemic stroke?
The treatment for an aneurysm that has not ruptured is often just to watch it. Don't do anything. It depends on size and the shape of it as to whether or not we're going to go after an unruptured aneurysm and familial risk factors. For an aneurysm that is ruptured, the goal is to stop it from having another hemorrhage. It's not continuing to bleed. You don't have that much space in your head. No one does. It's not like an abdomen or a leg. Okay, you can't just keep bleeding into your head. So the goal is to prevent it from happening again. There's a lot of things that can happen when you have an aneurysm rupture. And again, I'm showing you two people who look good. There are a lot of folks who look plenty sick and need a lot of things done to them. Generally, I can treat 95% of the aneurysms through the catheter the same way that Katherine's aneurysm was treated, by putting small platinum coils into it. Occasionally, I have to take someone to the operating room, open their skull, carefully push the brain out of the way, and put a clip on the outside of the blood vessel, thus reconstructing it from the outside. That determination is made by me. What is the safer option for this person? Sometimes we have to stage the treatment to allow us to use something like a stent. For ischemic stroke, is that it? I think that answered that one.
Yeah.
For ischemic stroke, if you show up within 4.5 hours of the onset of your symptoms, the onset, not from when you woke up, but from the onset of your symptoms, more often than not, we are able to give you a clot busting medicine called TPA or alteplase. There are reasons why we may not give alteplase. There's a short list, but very strong contraindications or reasons we wouldn't give the medicine. The other option, if you have a large vessel occluded in your brain or in the neck, is to go up with a catheter and actually pull that clot out. It is called a mechanical thrombectomy. It's just as great as it sounds. We're actually going up with a catheter, putting a stent into the clot, and then trying to snare that out or suck it into the catheter. It sounds heroic, and it sounds kind of scary, and it should be. It's not something we're doing on everybody, but if you're that person in that position, trust me, that's better than watching you continue to have that stroke, and that's why we're doing it.
Thank you. Okay, I think we're gonna answer some questions from the audience. There were two.
I
over
actually
here.
have some on the Zoom I want to get through quickly, and then
Yeah.
we can go to the audience.
Thank you.
The first is, if one has had large hemorrhages in the knees and hands due to an allergic reaction to gabapentin, can the drug also cause a hemorrhagic stroke?
I have not seen that.
How often do patients have a second stroke?
40% of people who have one stroke will have another. 40% recurrence.
I think we covered this, but we cover it again. Is acute pain in the head or headache a possible stroke symptom?
I think that should be a warning signal to anybody. This is, if you have regular headaches, and this is a bad one, but it feels like your regular one, it's probably your regular headache. If you have migraines, and this feels like one of your migraines, probably a migraine. If you hit your head and you have head pain, probably just you hit your head. When people have an aneurysm rupture, or they have a spontaneous subarachnoid hemorrhage, a bleed in the brain, there is nothing that you have felt like this before. You have never felt a headache like this before. It didn't come on over 2 days. It didn't come on over a week. It didn't come on over a few hours. It was 1 second to the next. You were normal, and then you have never felt anything like that before in your life. And it feels like your head is exploding. That is the headache that we're looking for. That should get your attention immediately, headache.
How likely is a 5-centimeter hypodense area in the brain to cause a stroke?
Unlikely.
Is there a treatment for hypodensity in the brain?
No.
Last, I have a caretaker here. My husband has had 3 strokes since 2019. He's recovering well, eats right, walks and exercises regularly. However, her worry is his anger, and he is not always very nice to her. Is there something that she can do? It's affecting her a lot, that he's had this sort of personality change since the stroke.
I think
That's a more in-depth.
that falls into my bag.
Yeah, it's definitely.
Sometimes that can be a sign of the stroke. Sometimes we do have some different personality kind of stuff that'll come out. Usually they are who they are, but sometimes they'll be a little quicker to anger. But Depression is extremely common after a stroke, and sometimes I don't want to make generalizations, but in general, sometimes men, that'll be their symptoms, you know, that quick to anger, angry more often, easy to upset. So it would be worth them talking to their doctor.
That's all I have online. So if everyone just wants to raise their hand, we can go around.
So how does diabetes increase your risk for a stroke? Is it a blood sugar thing or a blood pressure, or what actually is increasing risk?
Diabetes forms rock candy in. How does diabetes cause stroke? Diabetes causes stroke the same way that diabetes kills other parts of your body. Diabetes causes rock candy to form microscopically in blood vessels. Over time, it shuts off the blood supply to those organs. The brain is one of those organs. So if your sugars are out of control, just think, you're forming small sugar crystals that are shutting down blood vessels to vital organs in your body, the brain being one of them.
So you said rock candy?
I'm giving you an kind of a layman's term. But you've gone to a store, you've seen how rock candy looks. Imagine tiny microscopic that stopping blood flow into tiny little blood vessels. That is what is happening when diabetes is killing off organs, when it's injuring organs. Eyes, brain, heart, legs, nerves, all that. This lady right here was actually, yes, ma'am.
I've been prescribed since 2 doctors have seen me before. That's how long I've had 81 milligrams of aspirin. And I thought it was for stroke prevention, but I now read that that particular regimen is not recommended. But when I was told to take it, I was told that once one starts that regimen, that your body becomes used to that. And therefore getting off of it should not be done by myself, but in consultation with a physician. What is the current guidelines on
Sure.
81 milligrams of
Can you repeat the question?
Sure. The question is, and hopefully I can summarize this correctly. We used to use aspirin as primary prevention. So we have someone who's at low risk, no big issues, but we want to do everything we can to prevent a stroke or a heart attack. We used to say, all right, after age 50 or 55 in women, take a baby aspirin every day. That'll help, right? We now say, well, let's select those people a little bit better. If you have a family history, you have high cholesterol, you have very high, some blood pressure issues. We know you have a little plaque buildup on the carotid arteries. Then we would, or you're a diabetic. We would say, okay, yeah, you probably should be on a baby aspirin. But for your average person, low risk, no risk factors, their weight is good, I would say you probably don't need to be on the aspirin, because the risks now of bleeding and having ulcers and things like that, those risks are going to outweigh the benefits. And there's gosh, we could spend hours talking about blood thinners and ways to do that. The other part of the question was, can I just stop taking aspirin and, is that safe? I think the reason for that is probably because they want you to talk to your doctor and make sure you're okay to stop it, because maybe you weren't clear on why you were taking it in the first place, because that happens. Some of my patients are like, I just quit. And I'm like, well, you can't quit because you had a stroke and you need to be on that forever. And that's to help you prevent a stroke. So that might be some of why, but for aspirin and statins and certain blood pressure medicines, we know that when you stop it, there's kind of a week where you're at increased risk for events. And that's as your body's chemistry normalizes. So if you're starting and stopping a cholesterol medicine, aspirin, or certain blood pressure medicines, that stopping and starting can mess you up. So it's correct.
Dr. Neal, you had said 20 with the BMI, and I understood that 20 to 25 is normal. So do you really mean 1 point above 25 BMI, or were you really starting at the 20?
When they did the studies, it was 20, which is, I know it's sort of alarming, but it is what it is. I was shocked to find that too. Because usually when we talk about obesity, I'm also an obesity medicine doctor. We usually start seeing risks and, various things for cancer and diabetes risk and risk of sleep apnea and all that. Usually we're seeing that at a BMI of 30 or more, and then, once we get above 35, once we get above 40, we have a lot of risks. But this was an interesting thing that I learned doing a little research for this talk, was that it's actually 20.
Yes, I was concerned about how can you find out, how do you know the difference from when you having Bell palsy or stroke?
That's a great question.
That's a one.
Can you repeat the question for
I'll
you?
let him take that.
My daughter had a reaction of Bell palsy. Well, they said it was Bell palsy. Her face just lost all motion and then eyes shut down. She couldn't swallow anything, it was drooping. But when we took her to emergency room, they told me it was Bell palsy. I thought she was having a stroke. But that's what I'm trying to find. How do you know the difference on Bell palsy?
That is a great question. I'm glad you brought that up because that does scare people when that happens. Bell's palsy is an injury to a peripheral nerve. A stroke is an injury to the brain itself. Okay. The way that we know this is based on the exam. There's a lot of imaging that frequently happens in the emergency room to make everybody feel safer, but the truth is, looking at it was your daughter, so I'm assuming she was, how old was your daughter when this happened?
30.
Right, so the likelihood of it being a stroke is pretty low. More often than not, a Bell's palsy is an autoimmune disorder. So your body makes antibodies against parts of your body when a Bell's palsy occurs. We think that it comes after a virus, usually an upper respiratory something. It doesn't have to be that. And then the body makes antibodies against that virus, but it mistakenly makes some of those antibodies can also attack the body. Why this happens to the face, we're not totally clear. But what happens is the nerve that comes out to the face gets injured by those antibodies. It usually goes away with time. Sometimes it does not. Sometimes it's incomplete that it goes away. Based on their exam, we can see that that is an injury that is not in the central nervous system, but instead in the peripheral nerve, to the facial nerve itself. And what that is when they have a stroke, when you have a stroke, your forehead still works. That's because of the anatomy in the brainstem where the facial nerve originates from. But when it comes out and it's actually going out to the face, it no longer has support from the other side. In the brainstem, you have innervation from both sides, and once it comes out, it's only on the one side. So when their forehead is involved, it's almost always a peripheral nerve injury, not a stroke. It is a neurologic deficit, but it's not actually an ischemic event. And the treatment and the pathophysiology, the underlying what happened here, is different with a Bell's palsy as compared to a stroke. So the biggest thing is her forehead is down as well. So when we say smile, even with a stroke person, they can raise their eyebrow, whereas with the Bell's palsy, they cannot. Okay?
Is there any type of screening, pre-screening, to see if a person has predisposition to having a stroke? I have diabetes, I've had a long history of migraines, I've had a heart attack, I've had cancer. I have stents. So I'm interested to know, and I've also had vertigo. Wow, I'm still intact.
Be great.
Is there any pre-screening to see if, my brain is blowing wind or something? To see if a
I'm going to
person
defer that
is.
to you, but I'm going to say that there's not. Are you asking like an MRI of the brain to see if you're having strokes?
Any kind
Well,
of pre-screening?
If you're not having symptoms, so when we talk about just your average person, No real big risk factors, nothing going on. They come into their doctor, we discover you have high cholesterol, you have high blood pressure. You don't really have much of a family history. I would say, your two risk factors are the blood pressure and the cholesterol. Let's address that. Let's assume that, maybe this would go on to cause you some trouble down the road. Very early prevention. If we have somebody who we know is really high risk and maybe has some symptoms that could be stroke, then we're really kind of, we're not just doing screening like anybody would get. The U.S. Preventive Task Force does not recommend for carotid ultrasound screening like they do in the life screens that come through town, unless you're really having symptoms or you're very high risk. In people who we know have artery trouble, they have already had a heart attack. They have already, we know that there's some, they have trouble with the arteries going down to their legs. I would, probably consider a carotid ultrasound or some other imaging of these arteries and see what they look like. Now, what would I do about it if I knew you had it? I would say, well, probably a lot of the same things you're already doing. Control your blood pressure, control your cholesterol, maybe be on some sort of blood thinner. You're probably already doing those things for heart. Then the question is, well, what would it change if we did know this was there? So you got to kind of talk to your doctor about some of these screenings because, just because you find something out, well, what can we do about it? How would that change things? How would that help us figure out how to better take care of you so that you can have more happy birthdays?
I've also had Bell's palsy.
Oh, no, all the things. Yeah, well, you may have your doctor in love.
Scientific experiment. My mother died of a massive stroke.
Oh, I'm seeing some imaging in your future.
Yeah. So that was why I asked.
Yeah, it might be worth.
I walk and talk and exercise every day, and I'm amazed that I'm still moving.
Good. That exercise might be part of why.
Just a quick comment with a quick question. My mother had a massive stroke and she was a heavy smoker for years. Never coughed, never had any breathing problems, had an ischemic stroke. Could never stand the smell of cigarettes after that. Just, so you do get the personality changes. And now my question is it only with the aneurysm stroke that you have the headache?
There are people who have headaches associated with ischemic stroke. I don't know exactly why.
Is severe? Would it be as severe?
It would not be as severe. More than that, most folks who have an aneurysm rupture are not going to necessarily have the lateralizing symptoms like somebody with an ischemic stroke. But that headache, I can't tell you from personal experience. I can tell you from doing this for years, what these two are describing to you is something that only they are able to describe. And they even there, they lose words on trying to explain to you what that felt like. So that headache is like nothing anyone's ever felt, as far as I can tell.
Not fun.
Oh, no, I'm sure.
We have one question over here really quick.
This is a follow-up from the caretaker I talked about earlier. She just was looking for some advice on how to get her husband to maybe talk to the doctor about this, because he doesn't seem to think it's a if you have any advice about that.
Doctors can always receive information from spouses and loved ones and neighbors and whoever. We can receive, we're not going to tell you anything necessarily unless we have a permission, due to HIPAA laws. But we get a lot of concerned citizen phone calls, and sometimes that really helps to know that, my patient so-and-so is probably having some issues. Now I can't make him go through the CT scanner. I can't make him take his cholesterol medicine, but I can at least open the door in a kind and sensitive way and say, hey, any numbness or tingling in your arm or leg, and usually at that point they'll say, yeah, I have been. They might be thinking, have you been talking to my wife? And I may say, we got a concern phone call, if I have permission to do that. But sometimes I'll just kind of bring it up in a sideways sort of way.
I have a question. I'm with CHP forever, and I used to get the normal blood profile test as part of my wellness exam. And I was taught to look at the triglycerides, the cholesterol, the HDL, LDL, and all that. And I was wondering and I use that more as a measure of how more intensely I should be doing what I should be doing. I mean, basically it was a disciplinary matter for me. Like this, how significant are those? If you were really trying to manage a good health, a preventative program for yourself, how significant are those indicators that one gets annually?
Definitely deferring that to Dr. Neal.
Lipid
I'm
panel.
gonna say important, but now I'm gonna say Dr. Neal can answer that.
It is important. And I think, it depends on if you're on medicine for it or not, because the medicine tends to control it. And then you're like, I'm good, I can have that hamburger. But really, you should still not eat that hamburger, or your whatever you shouldn't be doing. So I wouldn't let it, make you feel complacent if your numbers look good. But we do know that HDL, I think of it as your happy cholesterol or your good cholesterol. We want that level high, up to a certain point. The LDL or the bad cholesterol, we would love to see that number low, especially the very low density particles that we get on a regular panel these days. Those go up and down relatively slowly. They're not as impacted by fasting as they used to be, maybe still a little bit. Triglycerides go up and down, up and down, up and down all the time, depending on what you eat. So if you have some big old thing of ice cream, you go in there, your triglycerides will be pretty high. Sometimes people have triglyceride problems that are familial, and those numbers are always shockingly high, and they're not going to get better when you do a fasting lab. And the triglycerides actually are one of the better indicators for how you're going to do, for heart attack, stroke prevention, all-cause mortality. Triglycerides actually are probably our best measure. As doctors, we don't pay as much attention to it because we see them doing this all the time, and it's hard to really grab hold of it and say, what should we do? But I think the take home is that because it is so dependent on your day-by-day nutrition, yes, you should day by day be eating correctly. Take your food like a medicine. But that's kind of a little bit of a rundown on how I think of lipids.
Yeah. Is there anything that we haven't? Yes, go ahead.
Excuse me. If you have no family history of stroke, are you less likely to have a stroke?
Statistically, yes. However, that a great number of strokes that occur, there's no familial history of stroke.
Yeah.
That comes down, that's another one, like how much weight is weight loss, how much weight is too
So you
much.
have to look after yourself.
Oh, yes.
Yeah.
That's common sense.
You don't want to be the first one.
Right.
I would-
Ruin your family history.
You were asking about anything else that we've not
Yeah,
covered.
anything we haven't covered.
I think
you guys
maybe-
would like to.
You've heard us talk about the statistics of stroke, about subarachnoid hemorrhage. The statistics are, you're still dealing with a high rate of death and disability associated with these diseases. And there's a lot of folks that are going to have a less than perfect outcome. There are a lot of folks who are going to end up, unfortunately, in a position of dependency afterwards. I would say that the two biggest things that I wanted to drive home were quit smoking, make your family members quit smoking, and control your weight. I think the third thing that I think everybody should have a plan for is what happens if you're unable to communicate. You have that discussion with your family. Do not be afraid to have that discussion with your family. What are your advanced directives, right? We want to know when you come in and you're on a ventilator, or if someone's on a ventilator, how are we treating you? What would you want done? And having that discussion with your family on the front, I can't tell you what a relief it is to be able to have a very frank discussion with people's family members, because I don't know you when you come in. I'm not a primary care doctor. I'm not following you for years. When I meet you in the emergency room, I'm often dependent on someone else to tell me what you were like and, you know, what a nice person you were and what you would want. Yes, sir.
We did that the last time we were in this room. We did the 5 wishes.
Good, fantastic. I think that's important. Yes, ma'am.
It seems as though half the people I know now are using CPAP. And so I'd like to hear more about, is that just kind of the norm and kind of that may happen, or?
I have a perspective on this and she has a perspective on this. And if we have time, I get into it because it is important to go over. But is the norm? No.
Probably a good topic for the next Savvy Senior.
That's a really good topic. I would say when both of us were in medical school, I would say maybe with Florida State it was a little different, but we were not focused on sleep apnea. When you talk about sleep apnea, it was like, okay, this person snores. Okay, and doing what I do now and dealing with people whose blood pressure is wildly out of control, now they've had a hemorrhagic stroke or an aneurysm rupture or something like that, we're trying to get them off of IV medication just to get them to the point where they can be out of the ICU. I now recognize that sleep apnea is a major contributor to out of control blood pressure. Huge risk factor. Your blood pressure is fine all day. You fall asleep at night and you can't breathe right, your blood pressure is skyrocketing out of control. And I'm seeing that because I can't get people out of the ICU. So I now look at sleep apnea, and we know that the mortality and morbidity associated with sleep apnea goes up immensely. Length of life down with uncontrolled sleep apnea. There's a lot of good data on this, and this has all exploded in the last 20 years. So I think of a CPAP machine as an absolutely critical medication that you were supposed to be using. And is it the norm? I don't think it's the norm, but at the same time, we probably weren't screening for it much 30 years ago. So by all means, if you have sleep apnea, if you're supposed to be wearing a CPAP machine, do it. Figure out how you're going to make that comfortable. Gotcha. But so is me coming in and telling you to move your right side and you can't move your right side.
Excuse me, my son, I can't sleep.
Yeah. I think we were running out of time.
Oh, okay. She had one last question.
Just wanted to say, I've had sleep apnea for 20 years. I was diagnosed when I moved to Florida. I said to the doctor, God, I sleep terrible. This is my regular doctor. I said, I wake up 1,000 times a night and flop around in the bed like a fish out of water, and I'm up to the bathroom at least 3 times. And he said, well, you probably have sleep apnea. And that was when you really never heard of that.
Yeah.
And I thought, no, not me. Well, I went for a test and it was bad. I had to, stay overnight and have the sleep study. And I've been using a CPAP machine ever since. And you get very used to it. It's just part of going to bed. And there are a variety now of different kinds of facial masks. Nose buds, you don't have to wear a mask over your full face. But the machines are very expensive. So if you have one, you want to use it, because I understand if you don't, Medicare will take it away.
It will.
And my diagnosis was central apnea, which was extremely rare at the time. And I've been seeing Dr. Campo for 20 years. Now he has sleep apnea. And he told me a few years ago that they tested 700 people in a year, and 400 of them had sleep apnea.
Please don't blow it off.
Well, thank you all, and that brings us to thank you for the panel, for sharing your stories and the positions. We will be sending out an email to everyone who registered with a recording of today's talk. If you'd like to learn more about stroke and the advanced interventions available at TMH, please visit tmh.org/stroke. And you can leave all your trash sitting right there at the desk. Thank you. Thank you.